There we go.
Okay, so I think it's recording now. Let me go ahead and share my slides once more. And then, are you guys able to see my screen?
Yes, sir.
All right, thank you. So, so this is again the Medicine for Psychiatrists course. We have 4 hours together. Last time we had specifically talked about diabetes and the insulin resistance spectrum. So what do you guys remember from last time? What was your takeaway?
I remember it's important to get a fasting blood glucose and blood insulin so that you can do the HOMA-IR ratio to look at insulin resistance.
Okay, wonderful.
My takeaway is that it's not just the primary care doctor's like job or problem to deal with it. Like as psychiatrists, you know, part of our responsibility is screening, and that insulin resistance diabetes, it all falls under our umbrella as well, especially given the medications that we prescribe.
Yeah, I'm going to share some data with you guys in terms of our population and the risk of having cardiovascular events. Anything else?
Don't be afraid to prescribe metformin, which I've done many times, but not as a psychiatrist. I did it obviously as medicine and as a primary care flight surgeon. But
Yeah, we should be able to do that. Lots and lots of reasons to do that, whether it's primary prevention or secondary prevention. When we put someone on a high weight inducing medication and they're stuck with it, then that's one way to mitigate the effects. Anything else?
Just the importance of catching it early, not waiting until a patient is a full-blown diabetic and trying to catch them when there's early signs of the insulin resistance. It can have a big impact on their life going forward.
Yeah, and I think the last thing I would just reemphasize is the inadequacy of our screening tests. Unless you're doing 2-hour glucose tolerance test on people, right? Just because it's negative doesn't mean that you have completely ruled it out. So with that, we're going to switch over to hypertension today. And as you guys see, all of these fall under the metabolic syndrome. So here's our objectives. We're going to talk about the 4 categories of blood pressure. So get your Googling ready. And it's okay to look this up because ultimately my goal is to engage with you guys and create long-term memory tracks, essentially. So hopefully this will be active learning as I ask you these things. So 4 categories of blood pressure, and I'll give you a hint. One of them is normal blood pressure. And then there are 3 other ones. So we'll talk about those. This time, one of the things I noticed last time is I should have probably provided the proper definition of metabolic syndrome. So I'm going to do that. We'll have that in front of us and kind of re-emphasize what those 5 criteria are. Because I think unless you truly have that in the back of your head, you may not be sensitive to it. Now, I also want to show you what the impact of blood pressure control is on cardiovascular events. I think that's sort of interesting, and I'm going to contrast that with our suicide rates. Blood pressure measurement techniques. So when you do end up with that patient who shows up and then they do his vital signs and the blood pressure is sky high, what sort of things you really need to know as a psychiatrist to make sure that you're not dealing with bad data. We will obviously talk about what the definition of hypertension is by the categories of blood pressure that we'll discuss. And then if you happen to be one of those people who realize that someone does indeed meet diagnostic criteria for hypertension, I want you guys to be able to understand what are some of the basic screenings that are recommended. So you diagnose me with hypertension, what else are you supposed to do after that? We'll discuss some of the classes of antihypertensives, and there's an overwhelming amount, right? And I have my favorite from each of those classes, and that's all I deal with. A lot of the times we're limited by what's on the formulary, and then we'll just have a discussion on what you guys think your role might be in terms of going after this. So let's begin with a case. So this is also a real case. So this is a 34-year-old married white male. Weight there, BMI, as you guys see. And he is going through an MEB for chronic low back pain. He is seen for pain and significant anxiety. Previously was on a lot of different meds, was having anticholinergic syndrome because of it. He has a lot of obsessional anxiety about his poor health. And then he's constantly just obsessing over that. And that causes him a lot of suffering. So working diagnoses is OCD, and he's titrated to fluoxetine 80 milligrams. He's still complaining of a lot of muscle tension. He's got knots in the back of his neck. He feels restless. And then his heart rate, when you look back, tends to run in the 100s. Blood pressure is 142/88. All right. So imagine that is your patient. Your option is either just to ignore that, and you can tell them, hey, go see your PCM. And the chances of that are probably very low. And ultimately, patients are responsible for their own decisions, but maybe perhaps you could at least start by tackling the first few problems, because this patient needs help with their anxiety, and they're going to come see you, but they may not go see their PCM. So what would you guys do? So let me just kind of prime the pump a little bit. So who would diagnose this patient with hypertension now? And put that in the chart.
I don't think you can, because you need multiple elevations, right?
Okay.
But maybe I think it's either 2 or 3, but I think if you were to maybe look at his vitals like an Alta, and he had like his last 2 were elevated, and this is his 3rd one, then yeah, I think you can.
What else would you consider besides essential hypertension? It doesn't have to be you, Andrew, to answer. Anyone else? What else would you consider this guy might be having?
White coat hypertension.
Yeah, white coat hypertension. So any other considerations?
Hyperthyroid. Sleep apnea.
Yeah, so obstructive sleep. So you guys are now talking about secondary. And then Alex said hyperthyroidism, which is a good thought, given the, the tachycardia and so on.
Also his pain or his anxiety could contribute.
Pain and anxiety. And then how big do you think his arms are?
So that was going to be my statement, is I always check and make sure that the right cuff is being used to measure. Because if they use a cuff that's too small, it's going to make his readings higher than they actually are.
Yeah, so this might be bad data, right? So all of those. So those are all the things we have to consider. So we're going to try to tackle all the questions that you guys posed today. All right, so let's do this. So last time I had told you guys the definition. So this is what we usually go by. You got, this is an older definition. When we dropped the 110 to 100, then you ended up with this. But you've got 5 criteria. So you've got waist. And then just in the US, just remember, it's easy to remember 40 inches and 35 inches, right? Blood pressure, so greater than 130/85. HDL less than 40 for men, and then for women less than 50. What raises the HDL in women?
It's estrogen.
Estrogen. Now, in our patient population, there's a subpopulation whose HDLs are pretty high. In psychiatric population, even in men, because they use a substance that raises their estrogen level.
Alcoholics.
Yes. Yeah, so when you see people in the right context who might have the whole AST-LT ratios off and they have unusually high HDL, you know, you should suspect alcohol use. But yeah, the HDLs tend to be high in patients that have alcohol use disorder, especially the heavy drinker types. And so one of the other physical manifestation in alcohol use disorders that goes along with this is what?
Is it gynecomastia?
Correct, yeah. Yeah, so you know, they also end up with gynecomastia. And then if it's severely low in otherwise a muscular guy, what should you worry about?
Steroid use, possibly.
Yeah, correct. Anabolic steroid use. So some of those, there's like over 30 different type of anabolic steroids out there on the market. I believe stanozolol is one of them. Stanozolol or something like that, that does it, and it's used quite a bit by people for toning, apparently. Triglycerides are 150, so we had discussed that, and then fasting glucose is 100, right? So you need 3 out of those 5. Any questions on this? So I think when you guys start your clinic, take this slide and hang it on your desk. All right. Ooh. So so of all of these, which is the most sensitive and specific for metabolic syndrome? And you can look at the IDF consensus definition.
Waist circumference.
Yeah, yeah. But who here, be honest, who here has measured people's waist? We're supposed to do that, right?
I
So,
check it 7 West admission orders. I don't know if it gets done, but
yeah. So I think one of you, anyone who has access to those what am I thinking of? The little thing to measure, those measuring tapes. Get those and put them in your office, right? And if you don't like touching patients, you can have them grab it, turn around, and it's actually one of the requirement by the APA in patients with that are on certain medications or patients with schizophrenia, for example. So, and if you guys need them, I could probably acquire some from my medicine clinic. But it's those small ones. Okay, so here's the sensitivity, specificity. Pretty impressive, right? Given how crappy the sensitivity, specificities of some of the tests were. So again, if you have someone with really high waist circumference, more than 40 inches in men, more than 35 in women, and you get an A1C and a fasting blood glucose that are stone cold normal, you might be missing something. Okay, so metabolic syndrome in psychiatric population. So this is The Price is Right, and you get 1,000 cookie points for being close. So schizophrenia, what's the prevalence of metabolic syndrome in schizophrenia?
I'm going to go with 75%.
75%, wow, okay.
50.
50? Okay.
35.
35.
67.
6.
66.
All right.
25.
How about bipolar disorder?
25.
25. All right. So, and then here's an easy one. Who thinks that schizophrenia population has higher prevalence than bipolar? Okay.
I do think that, yes.
Yeah, so a lot of us do. All right. And then how about depression? People with major depressive disorder. Is that at risk for metabolic syndrome, or are they similar to general population without?
I bet they're higher than the general population.
Yeah, I think part of the confusion with MDD is the diagnostic criteria are so non-specific, right? So you could be fatigued because you're overweight. Now, the case that I discussed with you of this gentleman in the Coast Guard, I mean, is anyone surprised that he's having low back pain issues, all the extra weight that he has to carry? So I think we lost him, and I think that his obesity is really the culprit here in terms of the attrition. And now the Coast Guard has to, recruit another person and train him. And this guy is very, very smart. This patient, really just brilliant guy. And we're losing him because of obesity. All right, so let's see where you guys were. So that's schizophrenia, clozapine, 51%, and then unmedicated patients were 20%. So that's sort of the range, and that's the overall range. Here's bipolar disorder. So it's actually higher than schizophrenia in this meta-analysis. And in North America, half of the patient with bipolar disorder have this issue. And then again, there's a big difference, which just goes to show that antipsychotics equals obesity and metabolic syndrome. And major depressive disorder are higher, about 54% higher risk. So those are some of the data. If you guys want to deep dive into it, here are the references. All right, so blood pressure categories. So I gave you one already, normal. What are the other ones? Do you guys know based on current guidelines?
Hypertension, pre-hypertension, hypertension, I'm guessing.
Okay, so hypotension, pre-hypertension, and hypertension. Anyone else?
It's normal pre-hypertension, hypertension stage 1, and hypertension stage 2.
Okay. Anyone else?
Well, wasn't the second one called elevated?
Yeah, so pre-hypertension has been removed and now it's called elevated blood pressure. So anyway, so these are just, man-made categories, and then you guys even might remember that these used to be different. So here they are. So that's another something to paste on your walls in your offices. It'll make me so happy if I see these, if I come around and I see this. But essentially 130 or higher is considered stage 1 hypertension. And then stage 2 is anything over 140. If I remember correctly, previous guidelines, maybe 10 years ago, stage 2 was greater than 160. And so there has been changes, there has been changes over time based on new data. But this is from the ACC/AHA guidelines. Any surprises or comments or thoughts on this?
Why do they subcategorize it so tightly? Because, the last time I saw it, it was like 120 was normal, and like 120 to 139 was pre-hypertension, greater than 140 was hypertension. Like, I feel like people's natural ranges are going to vary, sometimes more than 10, millimeters of mercury in a given day, hour, whatever. Like, what's the significance of such small ranges?
Yeah. No, that's a good question. We'll talk about that. You guys seen The Patriot, right? the movie, Aim Small, Miss Small. So who likes to go shooting? Anyone into shooting at the range? By the way, we should have a residency trip event. There's a nice range in Virginia, maybe 45 minutes.
Do they have clays, like clay pitching?
Yeah.
Oh,
Yeah.
that'd be fun.
Yeah. And they have outdoors up to, I believe, 150 yards or 200 yards. And they also have pistol. Anyway, I digress. But when you're shooting, ideally, if it's a silhouette or something like that, you want to, so you're gonna say, I'm gonna try to shoot this person or the silhouette right where the heart is, rather than I'm gonna try to shoot him between his shoulders. So if you could make the target even smaller for yourself, then anyway, that's sort of a shooting fundamental there. So last time we brought in Al-Qaeda into our discussion, didn't we? The hunt for bin Laden. This time we brought up shooting range. Anyway, but now the hypertension criteria and the numbers that you use also differ based on who is doing the measurement and how they're doing it. So at home versus an automatic ambulatory or automatic oscillating blood pressure measurement, which, do you guys know what that is? So we have machines now where technically what you do is you put the patient in, you hook them up to the machine, assuming it's the appropriate cuff size, and then the patient is not able to see the screen. By the way, the patient should not really be staring at the screen when you're doing their blood pressure. You push a button and then you leave the room. And then you say, I'm gonna be right back. The machine is gonna go through a couple of these. And so what the machine does is it measures it 3 times and then it averages that. And that is much better than what we do a lot of the time, where we hook up the patient and they've been running from the garage trying to make it to the appointment. So anyway, so we'll go more into that, but there are 2 stages, and it matters because this then impacts what you do with your patient. So we'll come back to this. So why should we care? So this would partially answer your question, other than the shooting analogy. So it's highly prevalent. We talked about how prevalent the metabolic syndromes are in our population, and it's also deadly. So look at this. So as the blood pressure goes up, systolic or diastolic, regardless of what age group you're in, the absolute risk of stroke, the absolute risk of coronary artery disease related mortality goes up. So up to, that would be like an odds ratio of 2.5 right there. So it's extremely high. By the way, the thing that you do best with when we control people's blood pressure is you avoid strokes. All right, here's the prevalence of hypertension. And this also, it makes you think, right? So Black population in Africa, Nigeria, and the Caribbean, and in the US, right? So it may speak to lifestyle, it may speak to psychosocial distress, all of those things. And then here are US white population here. So, somewhere from 30% among the white population to The Black population, over 40%. And then this changes as we change the definition.
Do you know, Dr. Amin, if the prevalence has changed? Because I see this was from 2005, from the tightened ranges we just reviewed. Do you believe that the prevalence in the US has increased?
Yes, again, because those are man-made constructs, right? So if you lower the bar, then more people are going to fit in. But I don't know what that is. But even going by this, I mean, essentially, every third person that walks into your office is going to have it at some point.
So every German or every second German is going to be hypertensive.
Mm-hmm. Yeah. Now, this is prevalence, and so it includes a lot of old people, right? So your 30-year-old German is not going to be this. So a lot of this probably comes from older patients, and I'll show you some of the pathophysiology because I didn't want to deprive you guys of that. So we'll go into that.
I'm a little surprised that Spain and Italy with their Mediterranean lifestyles are so much higher than us.
Yeah, that's a good thought. Yeah, I'm not sure why.
Based on that, though, I wonder if you looked at, since it's prevalence, the lifespan of the people in Spain and Italy, and if they're capturing a lot of older adults.
Yeah, so it might be, right? Exactly, that's a good thought. So if there are a bunch of older people in Italy, then that's gonna kind of muddy the picture and raise their prevalence, even though they just happen to be living longer. So here's the thing that should also add to the discussion: what happens with aging? So our blood vessels are supposed to be compliant, right? So in systole they stretch, in diastole, they essentially squeeze. So how many hearts do we have? One. So people would argue that we have 5 hearts. So essentially the 4 extremities and your heart itself. So when you walk, you're squeezing blood, right? So all the squeeze and all the pressure that's generated helps the circulation. So one of the things that happens with people that we worry about with the OIF, OEF, the amputees who are missing their legs is they're at higher risk of heart failure because they don't have that same assistance, the peripheral assistance that all of us do. So the diastolic blood pressure really comes from the compliance, essentially, because that's when the heart's in diastole, right? So it's really what the aorta and the major arteries are doing that's coming to wherever you're measuring it. All of that. If these guys were solid lead pipe, we would be in trouble because every time our heart was in diastole, we might, feel dizzy. And so, but when we get older, our arteries change, they get non-compliant and they get stiff. So look, our systolic blood pressure goes up, our diastolic blood pressure goes down. So, this is called pulse pressure gap, but it widens. So these patients are at high risk for falls and stuff like that if you overdo their blood pressure. But as you see, so age obviously is an independent risk factor for hypertension because of just the way our physiology is. All right, this is our favorite chart. So you guys remember, so these are the factors that affect blood pressure: cardiac output, which is your heart rate and your stroke volume; peripheral vascular resistance, so how much your arteries are squeezing, how much volume there is. All of this is common sense. The viscosity of your blood, and then the elasticity of your vessels. their walls. And so what controls all of these is our sympathetic and parasympathetic nervous system, as well as the renin-angiotensin-aldosterone system. So what is the role of renin-angiotensin-aldosterone system? What does that do? You guys remember back from when you studied this long time ago?
I think it's, so this is really reaching back, but I think it starts in your kidneys, and then it has some effect in the lungs, and then it goes back to the kidneys, and it deals with like the afferent, efferent arterioles in the kidney to regulate blood pressure there.
So ultimately, what happens with the angiotensin, renin-angiotensin-aldosterone is renin has some vasoconstrictive effect. Aldosterone ultimately retains salt. And so if it retains salt, then which of these factors is it impacting?
Volume.
Yeah, so you retain more water, right? In order for you to, so it has effect on the kidneys, and then the rest, peripheral vascular resistance, is a sympathetic system. And then the vagal system affects your heart rate. So your cardiac output is going to be affected by that. So this is that. Now, on this picture, there's one label that deals with us. It's all the way at the top of his head. Stress, right? It says stress. You guys see that? So stress. So that would be essentially a cognitive, or you could even call it, you know, a psychogenic impact on any of these axes, but specifically on the parasympathetic and sympathetic nervous system. So there's lots of studies out there that show that people with anxiety and a lot of stress have high blood pressures. And if you've been stuck in the traffic in the last 48 hours, then your risk of having a heart attack goes up, stuff like that. This is going back to the angiotensin-aldosterone and this is where ACE inhibition happens. This is why you get coughing. The bradykinin builds up when you block the ACE here. And then on adrenal cortex, it has effect on aldosterone, sodium retention, and so on. And it can also activate sympathetic activation. Now, there was a study going on for PTSD that Dr. Benedict is, I think, PI on. Do you guys know what they're looking for as a treatment for PTSD, targeting this system? You might have seen flyers. I've seen them with their tables outside recruiting people, but they're looking at ACE inhibitors, I believe, in ARBs. So these are some of the secondary causes of hypertension. So probably the most prevalent is primary aldosteronism. So in primary care, we start to get suspicious when you put someone on their third medication and you have ruled out non-adherence and all that, then you can screen for that. But these are some of the other items. And the Fios and Cushing's are really rare. So these are some other reasons for working up, but that's beyond the scope of today's discussion. So going back to the question that Andrew had posed on why should we have our categories in, you know, essentially so close to each other. And here's the number of cardiovascular events avoided per 1,000 people over 5 years. And the 4 different graphs, it's not listed here, but these are people with more and more cardiovascular risk factors. So the blue one is no cardiovascular risk factors, and then hyperlipidemia, hyperlipidemia, smoking, you know, so 1 risk factor for red one, 2 risk factor for green one, and then 3 or more risk factors for the purple one. So, so the more risk factors someone have, the bigger the bang for your buck. And I think that's a truism that we had discussed last time, is the sicker someone is, the smaller your number needed to treat is going to be. So they benefit a lot more. And as you see there, and then there's almost a 2-to-1 ratio of diastolic blood pressure versus systolic blood pressure. So this is the benefit. So what sort of, so this says cardiovascular events, so you could have MIs, you know, non-fatal, fatal MIs, strokes, all of those are in here. What is something that we worry about in psychiatry as far as impacting mortality as psychiatrists?
Suicide?
Yeah, suicide. So what's the rate of suicide per 100,000 person years in the US? Anyone?
I remember it's like in the middle of what Europe is. Is it around 13?
13? That's pretty close, yeah. And then in the Army?
About 20.
Yeah. Yes, the Army's higher, but when you do age adjustments, it ends up being similar. So anyway, so this is suicidal deaths, and I played around with the numbers a little bit. So it's Army, civilians. And so the daily risk, the daily odds of dying from suicide is 3.8 times 10 to the negative 7. All right. And so I wondered, I said, well, if you could get one of these people with, you know, 3 or higher risk factors, and if you could drop their blood pressure by 16 millimeter of mercury, is that going to be, in terms of its weight, is it going to be, would it weigh more or more beneficial than eliminating all the suicides if we drop to 0? That's 3.5 times 10 to the negative 5. Because I had to go to 69 or per 1,000 over 365 times 5 to get that. So what do you guys think of that number?
Well, it certainly just seems that paying attention to blood pressure will have a great impact relatively to the suicide risk.
Yeah, so it's two decimal points, right? It's like 100-fold, essentially. Like negative 10 to the negative 5 versus 10 to the negative 7. You know, you guys know what I mean? So I guess this would be, you know, when you're teaching, it's a KSA model, knowledge, skills, and attitude. This would be an attitudinal slide for me or for you guys to kind of have you look at these things slightly differently. I know that we're all about suicidology, etc. But our goal ultimately is to help our patients no matter what we do. And so it's important for us to be, you know, comfortable at least in step 1 and step 2 as we go through this. This is a good list that you can completely hit delete. So pretty much, it used to be where, you know, the recommendations were, you, if you're black, if the patient is black, start them on, you know, a diuretic, if or a calcium channel blocker. If you're this population, start them on something else. But now, just start them on something, as long as, you know, there are other indications. So, for example, you might start someone on a thiazide if they have osteoporosis, for example, because it tends to prevent calcium loss in urine, and there are studies that show that people have a reduction in hip fractures, for example. So you, just like in psychiatry, we consider other things when we put someone on a medication, same thing in primary care. Or, you know, I personally, unless someone has heart failure, I don't really start people on ACE. There's a high prevalence of cough. I just go with an ARB, for example. So in my practice, I usually, if I have a young patient who's otherwise stone cold healthy, I may start on a calcium channel blocker. But I usually just go with an ARB, because you don't have to worry about the coughing. Plus, it does more than just reduce people's blood pressure. It also has other positive effects on the kidneys and the heart. So here's, if you come across a patient who's popping up positive on blood pressure, meaning elevated or stage 1 or stage 2 hypertension, this slide may be a good one to print out and just give it to them and say, okay, go home, get a blood pressure cuff, and I want you to do this. And then bring me about 5 or 6 different, you know, readings. But there's a lot of stuff, like if people have a full bladder, they're gonna have hypertension. So, you know, when I was a resident, I would get called in the middle of the night that Mr. Smith's blood pressure's through the roof. And I would look, and it was like some elderly gentleman. I would say, wake him up, have him pee, and then call me back in 10 minutes when you repeat it, right? And so then the gentleman probably had a enlarged prostate, and so the bladder was really full, and then people have this sympathetic response, and then they would recheck, and then they would say, yeah, the blood pressure is normal now. So things like that. You guys can review this on your own, but these are some proper techniques to measuring. And then, are you guys able to see me or no? Just seeing the slides. So to measure the cuff size, you take the, let's say this was the cuff. You take that and make sure that it's 50% or bigger circumference of the individual patient's arm. If you don't want to do the whole measurement, there's I think I included a slide where it talks about specific stuff, but it needs to be, so for my arm, I don't have big arms, so probably medium would be okay, but it needs to be, you know, 50% of their arm, or you may have to use a thigh cuff. So here's the cuff sizes. If it's too small, it's going to show the blood pressure is too high. So if you get someone, you know, go check on your corpsman or medic and say, hey, show me how you did this. And if they're using the wrong cuff size, a lot of people do, then it won't be good. This is, so if someone's blood pressure comes up high, next thing you need to do is to have them bring you some measurements from home. This would be an instruction for them on how to do that. So like 5 minutes of rest time before not smoking, sitting correctly, take 2 readings, 1 minute apart, and then, you know, it gives them instructions on how to do that. So it's pretty helpful. So here's the money part. So So whenever you detect someone having new blood pressure, the first thing you want to do is to say, is this white coat hypertension or not? And so if they're if you suspect this hypertension, then the ABPM is, you got a referral people, then they get this blood pressure monitor, and then it keeps on going off at certain points of the day and night. So, or the home blood pressure monitoring, which would be this handout you'd give the patient, and then they can do their own. If they end up being normal on that, so if it's less than that, then it's white coat hypertension. You don't do anything. If it's elevated, then you would, call that, it's no longer white coat hypertension. And then here, if their home-based blood pressure is greater than 130/80, but in the office was low, then this is called mask hypertension. It's when people are the opposite of white coat, essentially. Then you're unlikely to come across. I've not really come across this situation much. So here's where you could help out. So let's say someone is elevated. You could ask them to go do that at home. You can check their, I'll show you how to do this 10-year cardiovascular disease risk in a second. But if they're less than 10%, then you can at least reassess them on your own as you follow them, especially if you start them on antipsychotics. You can refer them to diet, nutrition, and at least work on this arm. If they're greater than 10%, then it's recommended they get started on a medication. If it's stage 2, you diagnose them in stage 2, then you can send them to the PCM or start at least one medication yourself. Any questions on this?
Dr. Amin, I'm just thinking, as a resident, are we going to get pushback from our global supervisors if we try to start antihypertensives on one of our patients in the clinic?
Well, it will depend, and you should have that discussion with them, right? That you guys have had this training, and next time when I see the patient, I plan on doing this. Obviously, if they ever have discomfort with this, then I'm happy to just stop the case with you guys, and you can send your note to me.
Kind of along the same line as Kristen's question, even if you started the patient on an antihypertensive, would you still have them follow up with their PCM, so the PCM is also tracking the medication change, or would you just monitor that patient yourself?
No, I would recommend that you send them to the PCM, mainly because these are the recommended basic testing when you first diagnose someone. Now, if it's someone who has known history of hypertension and they were non-adherent, and they show up and they're hypertensive and they used to be on nifedipine 60, right? And they say, "Doc, I can't get into my PCM," then you just bridge them. And then they can go and see their PCM. But like ECG, you won't be able to do that. You can do these things yourself, right? But at least when you catch people, you can do this stuff, right? And then send them my way. And now you've already saved the patient so many hurdles. These are all hurdles for us in terms, or for the patient and us. And so the better we can reduce these hurdles as a system, and we're all part of the system, the better ultimately for the patient. So you know that when you send them to me in my primary care, I'm going to need some of this stuff to figure out what their 10-year cardiovascular disease risk is, for example, and I need some of this stuff. So you can just fire away some of those things, and then when they show up, I'm like, wow, okay, I already have all the data, and I don't have to keep on seeing this young guy who, people that age may not even want to see their primary care. So this would be, you know, feel free to bite on as much or as little based on your comfort, your global supervisor's comfort, and all that. Does that make sense? But
Dr. Mean,
yeah.
do you ever like think there might be like kind of an issue with I mean, depending on, I guess, the scenario with how well you know the PCM, if it's, you know, here at Walter Reed or whatever, but kind of like a stay in your lane, you know, from the primary care doc. I mean, I imagine if you know, a primary care doc was prescribing some sort of psych meds, I mean, obviously they're more than capable to do standard, you know, general treatments, but you know, there's always that inherent oh, they gets his psych meds prescribed by a primary care doc when you're like kind of staffing, or like that kind of dig. And like, I wonder, you know, if we're sending patients back to their primary care doc and it's like, oh, psychiatrists prescribing their blood pressure meds. Not that, again, we're not capable of doing that, but have you had issues? And not with you, I guess, being dual certified, but that would just be something that I would kind of figure might happen.
No, it's really not a thing in primary care. We literally have 15 minutes, and I'm glad that someone has duct taped something, and I'm grateful, usually. And there might be a time when you may want to take someone off of their blood pressure medication because you want to maximize prazosin dosing or clonidine dosing. So the reverse is also true, where you may want to, you know, do that. And it's okay to coordinate and email the PCM and say, hey, you know, I saw this guy. He was on nifedipine before. I have restarted it, and I asked him to see you, or put a TCON or something like that.
Okay.
Yeah, usually it's not. So I've listed a lot of these meds for your reference, and then what the typical doses are. I have really one or two from each class. I don't remember all of these. I've circled the one that we use in psychiatry. Pindolol, right, shown to accelerate antidepressant effects of fluoxetine if you combine it with fluoxetine. Propranolol we use a lot in psychiatry. We use clonidine, prazosin, guanfacine for ADHD in children. So what's the goal? So just remember this J-shaped phenomenon with hypertension. So there's a sweet spot, and then if you go too low or too high, the hazard goes up essentially. So we can't just, you know, bottom people out, and then obviously high blood pressure is also bad. So the goals have to do with then these. So people with known risk factors to be considered high risk population have different goals. So if they're measuring it at home, 120 to 125, if they're measuring it in your office, it's usually slightly higher. So this is what I meant earlier. And then 125 to 135 over less than 90 for home-based. So I'm a big fan of home-based blood pressure monitoring. Office-based tend to be not very accurate, especially if it's like a one-time deal. If it's the AOBPM, the automated oscillometric blood pressure, then those are more accurate. And the machines have those options in it. So this
Dr.
is,
Amin,
yeah.
sorry. If you write someone a prescription for an at-home blood pressure machine, will our pharmacy fill it, or do they have to go out and buy their own?
They used to. I haven't written one in a long time. People typically just buy their own. Around $50 is a decent one. Anything cheaper than that's probably not a good machine. And then you ask them to bring it to one of their primary care appointment, and they can just make sure that it's calibrated. Here's the stuff. So one of the element in that was the 10-year mortality, and this is what that, you know, this is all the stuff that goes into this. Here's the calculator if you guys are wondering. So back to this guy. So I'll show you what I did for him. So I tried this. Check your blood pressure at home. He was still elevated. So I ended up in stage 2 hypertension. And because he was still having a lot of anxiety, some nightmares, sleep disturbance, I said, we're going to go with clonidine first, even though that's not primary. So we just started that today, actually. And then if he's not at goal, I'm going to add losartan to him, to his regimen. But my goal is to improve his psychiatric symptoms in addition to controlling his blood pressure. All right, sorry. So we went through a lot of stuff. Any questions?
Sir, did you say that you were going to post these slides somewhere for us?
Yes, will do. All right, so I'll give you guys a few minutes of a break, and then if you guys have any questions, we can discuss those later. Sorry, I went too long. Thank you, guys.